It's a great honor for me to be here at the Empire Club of Canada today, which is arguably the most famous and historically relevant speakers podium to have ever existed in Canada. It has offered its podium to such international luminaries as Winston Churchill, Ronald Reagan, Audrey Hepburn, the Dalai Lama, Indira Gandhi, and closer to home, from Pierre Trudeau to Justin Trudeau. Literally generations of our great nation's leaders, alongside with those of the world's top international diplomats, heads of state, and business and thought leaders.
It is a real honor and a distinct privilege to be invited to speak to the Empire Club of Canada, which has been welcoming international diplomats, leaders in business and in science and in politics. When they stand at that podium, they speak not only to the entire country, but they can speak to the entire world.
Good afternoon, fellow directors, past presidents, members, and guests. Welcome to the 116th season of the Empire Club of Canada. I'm Mike Van Solen. I'm the president of the Empire Club, and I'm delighted to be your host for today's virtual event titled Being Older in 2020, The Modern Joys and Risks of Aging. We could not hold these events without our very generous sponsors. I'd like to thank our lead sponsor, Home Instead Senior Care. I'd also like to acknowledge our supporting sponsor, Home Care Ontario. I'd also like to acknowledge our event partner, VVC and livemeeting.ca, Canada's online event space. Thanks to them for webcasting today's event. And as always, thanks to our media partner, the National Post. Of all the changes that are predicted to come out of this pandemic, perhaps the most pressing will be the changes to the way we think about and care for the elderly. The devastating impact of COVID-19 on our long-term care homes and retirement communities are well known. Many provinces have already committed to some form of public review or inquiry to determine how we can do better in the future. But the questions of how best to care for the elderly as they move into the old age is a challenge, and experts know we have a lot of work to do. Life expectancy in Canada is now 82 years old, meaning that we're living 25 years longer than we did a century ago. As baby boomers enter retirement, they could well have 2 decades to look forward to. Those years could be spent traveling, volunteering, and acquiring new skills, or they may be isolated, dealing with medications, confined to their homes or beds. Our panel today will address these difficult questions and more around aging and ageism, and help explore how to better support the seniors in our lives. Please let me introduce our all-star panel. Today, we welcome Dr. Samir Sinha, the Director of Geriatrics at Mount Sinai and UHN Hospitals. In 2012, he was appointed as the expert lead in developing Ontario's senior strategy. He is a Rhodes Scholar with a doctorate from Oxford University's Institute of Aging, and we are thrilled he is able to join us. Michael Nyssen is the Executive Director of the National Institute on Aging. He served previously as the Chief of Staff to Ontario's Minister of Seniors Affairs, where he worked with Dr. Sinha in designing and launching the province's senior strategy. He has also worked as the Director of Policy and Strategy Planning for CARP, the National Advocacy Organization for Older Canadians. Margaret Gillis is the founding president of the International Longevity Centre Canada. The center is part of a global network dedicated to the needs of older people and protecting their rights. Margaret helped establish the Age-Friendly Communities program, which is now spread to more than 900 Canadian communities and more than 26 countries worldwide. Due to unforeseen circumstances, unfortunately, Mary Walsh is not able to join us today, but I trust our other panelists will up the humor in their answers to make up for a regrettable loss. Here to interrogate the excellent panelists is the Globe and Mail's health columnist, Andre Picard. He is one of the clearest and most compelling health writers working in Canada today, and he is the author of the book, Matters of Life and Death. Before I turn things over to Andrew, please know that this is interactive meeting. You're able to submit through your web browser questions to us. We will try to go through those and Andre will work them into the questions he asks of the panelists. Thanks so much for attending today's event. We hope you get a lot of insight out of the discussion. And with that, I will turn it over to Andre.
Great, thank you, Mike. Thank you for everyone for joining us online. As you heard in the intro, this is a time of unprecedented attention being paid to our elder population, to our elders, what's going wrong in our long-term care centers because of COVID-19 and what good can come out of this. So we want to touch on all those topics today and talk about aging and ageism more broadly. But I want to start with our panelists talking about this elephant in the room, about COVID-19. Why did things go so terribly wrong? We have in Canada about 6,000 COVID-19 deaths. Somewhere between 4,500, 5,000 of those deaths are among our elders, almost all of them in some form of institutional care. So I want to just briefly, we could of course spend hours talking about this, but just briefly talking about what went wrong, that's so terribly wrong that this population has been so hard hit. And maybe, Samir, I can start with you. You talk a lot about this. 80% of our deaths are in a population that consists of 1% of the Canadian population. How did this go so terribly wrong?
Yeah, well, I think let's start with what went well. I mean, I think in a fast-moving pandemic, with something like COVID-19, we know that these viruses or other infections, they tend to prey on the young who have weak immune systems and the older amongst us whose immune systems are naturally weakening. I think what's really created a stark contrast here is that COVID-19 seems to be sparing younger people, unlike the older population. We don't know why. It's just what it is, unlike the Spanish influenza, which had a predilection for younger people. So that's the first fact of what we actually know. But the good story that we have is almost a tale of two pandemics, is that we actually saw that because we implemented our physical distancing and our lockdown measures earlier than where other countries did, we actually had a story of while we had enough community spread, it didn't lead to a huge amount of deaths in the community amongst people of all ages, especially the older adults. But what we have seen is this tragedy of 80% of our deaths occurring in long-term care homes, which are pretty much where our frail, vulnerable, older adults with multiple chronic issues are housed. And I think what this has done is it's just exposed the systemic vulnerabilities and the examples that we never learned from SARS that other countries like Hong Kong, South Korea, Taiwan, Singapore did, and why those countries that were also hit like we were with COVID haven't seen any deaths in their long-term care homes. So that's where I think the real tragedy is this has exposed that we neglected to follow the advice that we should have. And here's where we stand today.
But we knew this was a vulnerable population. Why didn't we do more? Why did we pay so much attention to hospitals, so little to long-term care?
I think the reason why we spent more time on hospitals, for example, is that we saw what was happening in Italy. We saw what was happening in other countries, and I think even I thought, that wow, maybe the folks were dying in the community and dying in nursing homes in those countries to huge numbers because they just couldn't get access to hospital care. And so I think, like most other places, we focused on our hospitals. We underestimated what this could look like in our long-term care settings. And more details are coming out now, including in the Globe, just as of yesterday, about maybe there were decisions that are being made that actually perpetuated and even enforced more deaths to occur in these settings than needed to occur at all. So there will be plenty of time for questions, but I think it just explains a little bit about why we've seen what we have.
And Michael, with the benefit of hindsight, what do you think we could have done differently to protect this vulnerable population that has suffered so much?
Right. Well, I mean, this is an issue that goes back decades. It goes back before I was born. It goes back before a lot of people on this panel might have been professionals. And so it's nonpartisan. It's possibly not even political. But I think what it really indicates is that we have a deep-seated social ageism towards older people. And I don't even mean the sort of acute sort of bigotry you see on the streets every day. I think just internalized ageism, and a lot of us might have it unwittingly. It wasn't 2 weeks into the global lockdown that we had, governors of Texas, major public figures saying, maybe the older people should, step out of the way, do their part, die, so that we could open up the economy. We had young people partying across North America, having a good time while all of this was brewing under the surface. So to Samir's point, we certainly have systemic issues, challenges we could have addressed decades ago. This is giving us an opportunity to look at it now. But I think we have to confront the fact that we just sidelined older people as a culture. And this is probably true across much of the Western world. Canada hasn't escaped it. But, we all collectively had this blind spot about long-term care, despite knowing about the vulnerabilities. And I think it's because older people aren't top of mind the way they ought to be, and the way I hope they will be after COVID.
And I can't tell you how many times in recent weeks I've heard people say sort of flippantly, well, it's only old people, they're going to die anyhow. The average survival in a long-term care home is less than 2 years. What do you think when you hear comments like this? I'm sure you've heard them as well.
Yeah, I mean, it comes up when we talk about intergenerational issues, equity issues across the generations. We have this way of setting up in our minds a difference between younger people and older people that is completely inorganic and ignores the fact that we're all a part of families, social structures where we interact. You could ask any number of survivors, people who, whose family members died, older family members died, they're grieving. This is not just an isolated older person passing away in a nursing home. It has ripples throughout society. And I think this is why we're possibly waking up to it, because, the 4,000 or 5,000 deaths that we've had so far, how many more people are connected to each of those individuals who passed away, who haven't had the rites of passage, the closure that COVID has prevented from happening? I think we're all realizing that it's not someone else's grandmother who's passing away. It could be mine. It could be my mother. It could be aunts and uncles. And I'm really hoping that this sort of wakes us up to the fact that older people are not separate from us. They are who we are.
And Margaret, maybe you could build on that a bit. Your job is to talk about aging, about ageism, but you were also touched personally as a family member was lost to COVID. So this really brought the academic aspect home.
Yes, it most certainly did. It really hit me the day that my brother-in-law died on the 6th of April, early in the pandemic, and he was 73. And his wife came back from meeting the funeral director to hear on the news that there were 4 dead in BC where he lived, all elderly. And so all of his life, kind of flippantly referred to in one line, all of the, great successes in his life. So it did hit quite personally, but it was not surprising to me as a person who works in ageism. And I wish I could say I was more surprised by what has happened in long-term care, which is really nothing short than a wholesale violation of the rights of older people in our country. We think of our country as
I think we're having a little problem with your sound there, Margaret. We're having trouble hearing you.
But, on the top of the list, but it certainly is not to live in if you're in long-term care. And I think that when with data just recently that out of 12 countries, we came up with the attacks on long-term care. And I think we have to really think about how we treat other people.
Great. We had a little problem with your sound there, Margaret, but I think we're figuring it out along as we go. You used the word flippant. Do we treat people who are older a little too flippantly?
Okay.
Hi, Margaret. I think you're back with us. I
am.
For
Sorry.
a minute there. So I was asking you, use the word flippant. Do we treat older people, take them for granted, treat them a little too flippantly in general?
I think really we have a society that is basically ageist. So your voice becomes less strong as you get older in the sense of having a place in society. And I think it's something that we really need to look at in terms of really being clear about giving older people voice. And they certainly need to have it with respect to what's going on with long-term care right now. We need to make sure with whatever response we have, that we have older people involved in making the their voices heard and making changes in Canada so that we have a system that works.
Great. Now, Samir, you work a lot with older people, some of even seniors are a lot of your patients. You see a lot of real people with real stories, very engaged in society. How do you get the rest of society to break beyond those stereotypes of just old and disposable and to see what you see?
You know, it's challenging. And I think picking up on what Michael and Margaret were saying is that we have this societal ageism, you know, that the idea that if you go into a local, drugstore, you see all these anti-aging products, right? You see all these commercials saying how you can stay young forever, because why would you want to age? It's almost that we know that once you reach that mark, you're going to be thrown away. And I think what's tragic is that, folks in our long-term care homes, for example, 70% of them are living with dementia, 50% of them with behavioral issues. So it's really hard for many of them to be able to say what matters most to them, to remind us and to be able to participate in the public discourse. We have many resident councils and many people in long-term care homes who can speak for themselves, but we have many who can't. And then we further marginalize the folks who work with them, right? So as a geriatrician, I entered, my specialty where there are 10 times as many pediatricians versus geriatricians in Canada, partly because, frankly, if you just do the economics, I could make far more as a surgeon or any other sort of ologist than I could make as a geriatrician. So it's that nature that we pay the physicians who work with these people the least. We pay people who work in long-term care far lower than what in publicly funded long-term care. We pay nurses and personal support workers far less than what we would pay the equivalent workers in a hospital setting. And so it's just all that systemic ageism that really makes it tough. And I think for a lot of my older patients, right, the usual reason why patients come to me in the end is partly because, they've had enough. They and their families have just said, we're sick and tired of being told that the reason I have this issue is because I'm old. They say, I think it's because of my medications. And I'm like, yeah, those 23 medications you're on are probably not helpful. And it's amazing how it's just about taking the time to listen, taking the time to understand, and taking the time to problem solve and figure out. And the challenge, I think the reason why a lot of older people get discounted is because by the time you have 90 years of medical history and medications and issues, it takes time. It takes expertise to resolve those things. And I think a lot of us just say, you know what, you're older. You're not contributing maybe as much to the economy now. You've had your prime, and now you're just tougher to care for. So why bother? And I think the key is that we really need to remember, and I'd like to remind everybody, is that if we play our cards right, we will one day become old too. In fact, most Canadians do. And how would any of us like to have any of what we're talking about be experienced by them or their families? And I think I'm hoping the one silver lining that comes out of the 5,000 deaths so far are the fact that too many of us have now been affected by this, that we will not allow this to happen to any more people and to us in the future as well.
And Michael, maybe you could build on that a bit. This fact we're living longer than ever. Shouldn't this be a good thing? Shouldn't we be celebrating this fact that, I know a lot of healthy 80, 90, 100-year-olds. The vast majority of people are healthy, regardless of their age. And why do we forget that?
Well, I mean, you work at a newspaper, bad stories sell. And I think, when we're talking about aging and when we already have that substrate of ageism, we always look to sort of validate our opinions and our impressions of what's true. So we see decrepitude, we see, the decline with age, and that's what we focus on. Samir already talked about the anti-aging miracles that are foisted upon us daily. But, our institute was a part of 2 studies that are very good news, and not just good news for seniors themselves, but for society more broadly. So we did one, for example, on social capital in Toronto, and I was sitting around the table with other partners on that project, and the assumption going into it was that that youth in general, younger people in general, would have higher social capital. That is, those connections that keep us tied to our institutions, to each other, social trust. When the report actually came out, the one group that rose to the top, having the highest social capital, the highest satisfaction, trust levels, older people, right? And so that's obviously a benefit to them too. But this is an untapped resource for society. How do we sort of let that trickle down to younger generations? And then, to add to the irony, that the group that has the lowest social capital, struggling the most to get on top of things, is the younger generation. So I think there are opportunities where we could build those bridges. And then more recently, there's been a lot of discussion on the happiness U curve. Right. So you tend to be your happiest when you're young. It dips when you're sort of going through middle age for reasons we all probably know well. But the peak tends to be in your 60s, 70s, and then 80s. Right. And so we see that people are living fulfilling lives. They're connected in all kinds of ways. We ignore these stories and we don't actually work hard enough to let that seep through society more broadly. There's, the cliche of elders and their wisdom, but I think there's something to that we've been ignoring for too long.
And are people still happiest at 60? Has COVID shattered that, or people still have that optimism?
Well, I mean, we haven't seen the studies yet, but I would have to imagine, because the reasons that study, for example, identified people being happier is as you get older, you learn how to cope with the pitfalls of life. You've developed relationships that are long lasting, stable, that bring you a lot of reward. So I have to imagine, without having proof on hand right now, that a lot of older people who are going through COVID might be dealing with it better than younger generations. They have the experience, the wisdom, they know how to temper some of the worst things that are coming at us. But we haven't really tapped that socially to understand how we could, use that in the way any number of societies have in the past, with elder councils, with, youth interacting with older people. And I think that also drives the ageism, that on the one hand, we have youth culture, and then on the other hand, we have older people, and there's nothing bridging that.
And Margaret, you're part of an international group of longevity centers. A lot of countries long to have what we have, right? People who live to 80, 90, 100. Why don't we value this and see this as such a great benefit that much of the world dreams of having?
I think you've hit the nail on the head. I think there are a lot of countries that are, envious of our way of life and systems. Maybe not right at the moment with respect to what's happening here with long-term care, but we do have that wonderful reputation and well-deserved. With respect to how do we not value it here, I think, again, we almost need to really think about how ageism has hit our society. And one of the things that really might be worth doing is having a real awakening in terms of ageism, and maybe even having some government programs that address it. When I work on this area, I sometimes think of feminism in the early days, where really basic things have to be brought to people's attentions in terms of ageism. And Dr. Sinha, mentioned some of them earlier, just how we have anti-aging products everywhere and birthday cards that make jokes about aging all the time. I think we really need to go back and think about how lucky we are and how grateful we should be to have all of this wisdom in our society, but we need to change our ways and think about it differently. And we just don't right now. We just do not value what old age brings to us, even though it's probably the biggest gift from the 20th century was the longevity that we have.
And the isms you referred to, sexism and ageism, these are all about stereotypes, about assumptions. How do you change those? Is it with, as you're doing with you, framing it as a human rights issue, or is it about just putting people out there who challenge those stereotypes? What's the best way to change people's minds about this?
I think you have to frame it as a human rights issue, and it's one of the reasons why the International Longevity Centre Canada has been working really hard to get a United Nations Convention on the Rights of Older Persons. It's one area where we don't have a convention like we do for people, we do for women, like we do for children. We know that those other conventions have been incredibly effective in changing the lives of the recipients of those rights. And I think we need to really think about how to make that happen. And it's a big mystery to me why the Canadian government has not jumped on the bandwagon with this. We've been putting pressure on them for the last 6 years, asking them to step up to the plate. And they haven't yet. And that despite the fact that Canada has such a rich history in terms of defending human rights at the United Nations and elsewhere. Just think of the role that we played from the very beginning. We had a Canadian drafter of the Universal Convention on Human Rights, and also in terms of the Charter of the Rights of the Child. And we've seen from that one that things like the drop in child labor by a third since the inception of that convention, all kinds of positive things in terms of longer life for children. And the same with the disabilities. There's been big changes in countries as a result of that convention, and it's a relatively new one. I just don't understand why we don't do the same thing for older people, and I think we have to look at that as an ageism issue.
Well, hopefully they're tuned in and they're going to pay a little more attention after that. Now, Samir, we're talking about rights. In Canada, one of the things we're most proud of is that you have the right to access healthcare. We have a Canada Health Act that guarantees us medically necessary care, which is defined as physician services, hospital services. Isn't institutional care, shouldn't that be an essential part of our providing for people, those who need institutional care when they have dementia, et cetera? Shouldn't that be part of the package?
Absolutely. I think, and don't forget about medications, right? When we think about pharmacare. So it's interesting because if you go over to, the other side of the ocean here, and you look at how most European countries have created their universal healthcare systems, they find Canada really curious because they say, wait a minute, you're the only, universal healthcare system that doesn't cover medications, in a universal way. We're lucky because for most older people across Canada, your medications are largely covered, but not fully covered. And then it becomes more precarious at younger ages. But when it comes to, care, and I'll call it hands-on care, for example, the whole spectrum of long-term care, which in many cases has been isolated to the idea of nursing home care in Canada. But in other countries, at the level of the World Health Organization or internationally, we talk about long-term care being, that ongoing care that someone might need, no matter what age, to deal with, kind of physical challenges, cognitive challenges, other things. And that can be delivered in an institutional setting like a nursing home or in one's own home. And the irony of this is that most other countries who have universal systems, they cover all of that because it is hands-on care. And we have this dubious distinction that when you look at Canada in relation to the other OECD nations, we spend 87% of our long-term care dollars, about $24 billion a year, on institutional care, where other countries like Denmark, they actually spend the majority of their dollars on home-based long-term care because A, it's actually cheaper and it's more in line with what people actually want. But the challenge is when you deliver care in people's homes where they're often invisible, it's hard to cut a ribbon, right? And I think that's why we have this weird predilection that, in our recent Ontario election, we had a bidding war amongst three political parties. They all said 30,000 beds. And it was really about who could build them quicker. And I think it was the idea that maybe because that means more ribbon cuttings for the premier and everybody else, when if you ask anybody in Ontario, and I'm sure anybody on this, who aspires to end up in a nursing home, I don't think anybody raises their hand. But this is where you want to have a system that A, is providing all the care that we need, because frankly, in countries like Denmark, where they've invested significantly in the provision of home-based care, they don't have to wait time to actually build buildings where we can contain people. That's part one, because we can actually just deliver that care in your home. And therefore, when you have more home care, you don't have 15% of people living in hospitals as what we call ALC, because we actually don't have that capacity. So I've been to Denmark. I took a delegation of deputy ministers and others there about 2 years ago, and these were the questions they were asking us. They were saying, why are you so cruel to your people? And I had CEOs who said, look at our brand new hospital. Our current hospital is 1,000 beds, and I'm so proud of my new hospital. I said, how many beds? He said, 800. I'm like, what, you're prouder of building a new hospital that's smaller? He said, well, we don't need all those beds because we have more home care available. And it was just, it boggled my mind that we almost have it completely backwards, and it actually costs us money to make the mistakes that we're making.
And Michael, I know you're very interested in this topic about putting people in institutions. Do we put far too many people in institutions instead of going and giving them care in their homes?
Yeah, and there's a number of ways you can look at it. Samir hit the nail on the head. Canadians don't want to be there. No one does. And it's not about the homes themselves. It's not about the effort and the energy put into caring for these people. But in a common sense sort of way, you'd rather be at home in community. We know this going all the way back to the Romano report in 2004. probably even before that, although I haven't read up on all of my history. But we could look at it from a systems point of view. Where is care best delivered? It's probably at home. And then there's, to Samir's point about costs and flipping the ratios, and feel free to correct me, Samir, you know the numbers better than I do, but I think it's cost about $100,000 to build a bed in terms of capital expenditure.
150.
150. So, I mean, I don't have the back of the napkin math right now, but if you add that up, 30,000 beds that people don't want to be, how could we better use that funding to establish home-based care at a robust level and keep people there as long as possible? There will always be a role to play for nursing homes. There will be a time for a lot of people where they can't be taken care of at home. Needs are too complex. But the ratio really ought to be as much as possible in home and community. And we reserve nursing homes as high quality places where people go for care when there's no alternative. But, there are challenges. I'd be irresponsible if I didn't say, we did some analysis on the costs of long-term care into the future, even before COVID. So if we maintain status quo with where we are today across Canada, we're looking at a tripling of costs in the next 30 years, right? Going from about $27 billion to $71 billion in the next 30 years. So we can't continue on this path. It's unsustainable. More work needs to be done to understand how to shift that model. But I think, as Denmark and other countries have proven, we could do that and potentially save money, or at least deliver more care for the same amount of money by shifting models. We just have to get rid of our path dependency and being locked into where we are right now with our current thinking.
But it's not just about money, right? It's about, we have to get people in the most humane, most appropriate care possible.
Yeah, certainly.
Yes, and I think.
Sorry, go ahead, Margaret.
Oh, no, I was just going to say, you just heard that there's going to be in Ontario a committee struck to look at long-term care, but you really need to be looking at the whole continuum of care. And I think that's the point the other speakers have made. We need to start at home care, look at long-term care, and also look at how it impacts the hospital systems. So it's really that we need to look at the whole system right across the board. And if we don't, I think we continue to have the same problems we're facing today. It really has to be more thorough.
And Margaret, when I do talks, I often ask the audience, I'll say, who wants to end up in a nursing home? And there's never a single hand that's raised. Is this an issue that we should have more say in, that people don't want to be there? They kind of end up there by default. Do we not have enough of a voice?
Well, yeah, I think that's a really important point, and it goes back to the issue of human rights. We should have the right to decide where we live and where our homes are, and having a system that is stronger and works like, Samir and Michael have mentioned, is exactly what you need to have so that there is choice. So if the system isn't there, there is no choice, but we need to make it stronger so that there is. And we really have to work on home care so that, a greater number of people stay healthy so they don't end up in long-term care, and also that they have the choice to stay at home.
And Michael, I wanted to come back to this, getting the institutional care, community care right. We also have to avoid making the mistake we made with psychiatric hospitals, with mental health, right? We emptied them out because they were horrible, but then people were sent into nothing. So how do we ensure that we still have that safety net, but it's not necessarily a big building where you can have the ribbon cutting?
Yeah, and I think, going back to your question about the Canada Health Act, I agree with Samir. I think it's an option we have to look at. But the one thing that I'm a little pessimistic about, or that I'm cautious about, is that it's great that governments have acknowledged that the system is broken. I think we've turned the page there. What I'm careful about right now, and what I'm a little bit worried about, is that we don't rush headlong into the easiest solutions, the lowest hanging fruit, because as Margaret and Samir both indicated, we're dealing with a complex system here. And I think the challenges of building it up to where we want it to be are greater now than if we had started from scratch in the 60s and 70s, the way we did with healthcare. So it's not just about envisioning the perfect system. I think we all have a vision of what the perfect system is. But what we have to do collectively, whether it's under the Canada Health Act, whether it's done provincially, is we really need to plot this out. And it's not about taking a lot of time, but it's about taking the right amount of time to figure out how do we seize the opportunity that we have now, as grim as it is, just to really do the work to flip that script, to build up home care while at the same time sustaining the level of nursing facilities that we need at the time being. And it's not going to be easy, but I think we have the moment to do it now. And then we just have to make sure that we do it properly and carefully.
Now, Samir, as Michael mentioned, these things are very complex and complicated. They're big systems. Is it fixable?
It is fixable. I mean, it would have been more fixable 5 years ago, or even if when we built out Medicare, we just actually followed suit with most of our European neighbors who had already included things like medications and long-term care and home care, if you will. So I think, as Michael said, is we've actually kind of made a complex system that's been layered on over the years. So I'll give you the example. In Ontario, elements of what we've just been talking about are governed by 3 separate ministries. We have a Ministry of Long-Term Care, which is really the Ministry of Nursing Homes. We have a Ministry of Seniors Affairs and Accessibility, that oversees our retirement homes, which also allow individuals in retirement homes in Ontario to get government-funded home care. And that's actually all governed by the Ministry of Health and Long-Term Care. And then don't forget the younger folks in our society who might be living in group homes or other things like participation house that many people have heard about. Well, that's all governed under yet another ministry or 2. So it's, in essence, we're talking about a whole system of care that has been so fragmented, even the way our own Ontario government actually administers it, that we really have to say is, back to what Margaret was saying, is what is the system that we're talking about? And if this is the type of care, then how do we actually not think about it in isolation as the nursing home issue or the home care issue? And I think this is something that I know our Minister of Long-Term Care in Ontario, Minister Fullerton, has said to me, that we need to not just think about the nursing home issue, but we need to think about how long-term care overall is done. Because again, there are methods that we can do to provide better care, and I think we can fix it, but it takes political will. There's a lot of shareholders that are involved too, that obviously want to have their say. And let's not forget the older population, or us as Canadians, who've said, none of us have raised our hands saying, we don't aspire to end up in a nursing home. But somehow the governments have basically said, well, sure, none of you want it, but how about we build 30,000 beds in the next 10 years? So I don't know where the disconnects have been, but I think hopefully we're now much clearer on what we want and what we need. And we now just have to have the political will to do it.
And Margaret, I'm interested in your views on this. Do you think it's fixable? If so, where do we start?
I absolutely think it's fixable. And I think we need to start with looking at across those 3 systems, all those coordinated systems. Just ask anybody who's trying to move a parent, into long-term care, how difficult it is. And it needs to be connected to home care. It's even difficult to get home care in the front end. So we need to look at the whole system. And I think if we do that, we could really change it up. And we've got lots of great examples internationally, and we can look to them. Samir brought those up in terms of Denmark, and in terms of long-term care, there's been some great changes in Australia. We need to look at those other countries and adopt them. We do that all the time with policy. We steal all the best from the rest of the world. Why aren't we doing it now?
And Michael, again, I've been writing about this for 30 years. We see dozens of seniors dying in a fire. We've had a mass murderer in our nursing homes. We've had COVID. All these disasters happen time and time again, and we always say, oh, it's terrible, we have to fix the system. Are we going to do it this time? Is this going to be finally enough to force us to do something?
I think it will, and I think it has to. And I think a part of the reason why I'm saying that is because the entire system has been implicated now, right? So if we're thinking about Lac-Mégantic, some of the fires that happened 5, 6, 10 years ago, in a sense, you can compartmentalize that. You could say this home wasn't, working to regulation, didn't have the right supports in place. Or if we're looking at the wet law for an inquiry, we could say, rogue person who caused a lot of damage. I think the fundamental difference here is that the entire system we're talking about has been implicated, right? This term that we're all now using on systemic vulnerabilities, we weren't using that before COVID. It's not about one home. It's not about one area. It's not about one part of a ministry. It's the entire system has been exposed to have fundamental weaknesses that need to be patched up. So I think that's the big difference that we're dealing with now. It would be akin to all hospitals failing simultaneously across the country as opposed to 1 or 2. So I think that system level focus is really the fundamental difference with the impetus to act this time compared to the past.
But we've had some good homes in this disaster. It's a lot of homes with no infections that acted quickly. We don't want to throw the baby out with the bathwater either.
Yeah, I mean, and there's certainly excellence, operational excellence, right? We'll see that kind of variety across various homes. Although, interestingly enough, we're starting to do some analysis, and it's not clear exactly what some of those factors are. You know, there was a report yesterday showing that infection rates in private retirement homes are lower than they are in long-term care homes. We know that municipal run long-term care homes seem to be doing a little bit better. So it still exposes a system that is fragmented, as Samir was saying, where the vulnerabilities aren't fully detailed, mapped out. But I don't think we can get away from the fact that we have a certain level of incoherence in the system, and where good stories rise to the top, I think those need to be implemented systemically. And then we need to cut out and move away from the problems we've identified where the challenges have been the greatest. But it's a system level challenge at this point. I don't think we could point our finger at one single culprit.
And Samir, I want to return to something you said at the outset, which we, especially I as a journalist, often forget, is that there's a lot of good out there, right? There's a lot of good care. There are good homes. There's good home care. Talk about what is good care for an elder.
You know, I think a good care is you know, I had the pleasure of working with Dr. Gail Donner a few years ago on looking at how we reform home care in Ontario. And I remember when we chose the title, we simply, you know, we chose a title called Bringing Care Home. And we recognized some fundamental things because we talked to thousands of Ontarians at that time. And basically, we have to realize that the unit of care is not the individual. It's actually often the family, you know, and that individual who needs care. So it's starting with them and saying, what do you want? What matters most to you? The good things about good home care and long-term care is when we actually focus on what families want. So right now, the whole issue about essential visitors not being allowed to come in is also sometimes neglecting the fact of what a visitor can do, because sometimes the only person that someone will allow to feed them is actually their daughter, who's been doing it every day loyally 3 times a day for the last 10 years. So it's understanding the importance of starting there. And I think systems that do that work really well. I think it's also making sure that when we treat workers well, when we recognize that why are we grossly underfunding our long-term care system compared to our hospital system, so that homes have created systemic vulnerabilities where they're choosing to staff and meet their care needs by hiring people on a part-time basis without benefits because it gets the job done. But then we also hear the opposite, that 80% of homes in Ontario were having trouble recruiting people. So this is where, when we respect our workers, we treat them well, we make sure that they've got the training and supports they need, when we're listening to the individuals, and when we're actually funding to build proper care environments or the proper mechanisms to provide care at home. You know, this isn't rocket science. I think we have deliberately made decisions as a society. We've allowed our politicians to get away with decisions that we're okay with because it's not us, it's somebody else. But now, like, the truth of the matter is that, you know, the group that votes the biggest or at the greatest rate are older Canadians. There's 6.7 million of them right now. 80% of them vote. And I can tell you, a lot of them have lost loved ones, you know, either their own friends, their families themselves. And I don't think people are going to stand for this anymore. So we know what the fundamentals of good care look like. The key is, you know, I think we need to be ready to actually address them properly.
And Margaret, Samir made that very important point about family caregivers. They're so essential. They do a lot of the heavy lifting, literally and figuratively. What are their rights in all this? Beyond the individual has rights, but what about the family unit having rights to their loved ones being cared for?
Well, of course, rights are a two-way street. So of course, we were concerned about the rights of the older persons, but part of that is the rights of their families and the rights to be connected to their families and to see their families. So I think it's the same side, you know, two sides of the same coin. But I did want to make one quick point. Earlier on, you were talking about how are we going to ensure that something actually comes out of this. And I'm going to go back to my argument that we need a convention on the rights of older persons, because what that would give us, including groups like ours, you know, International Longevity Center and the National Institute on Aging, the opportunity to go in front of the Human Rights Council of the United Nations if Canada doesn't make changes to long-term care. And I think those kinds of voices are needed as well. And I think we have seen that the wholesale loss of rights of older people have made clear that they aren't protected by rights in Canada right now. So I think we need to be thinking about that as well. So I just wanted to make that point, going back to an earlier point.
And when we talk about rights, we often think of the law, we think of the courts. There are undoubtedly going to be lawsuits, criminal pursuits that come out of this disaster in our long-term care homes. Is that going to move the issue forward if we take the legal route?
Well,
I think, I think it's important for people to do what they think is right in order to protect their own rights. And legal route is one way to do that. And what we've seen is very severe. People died of dehydration. They died of malnutrition. I mean, it's unbelievable what's happened in our country. It's the kind of thing you would never expect to happen in Canada. And we would never have let it happen in a daycare or a school or university dorm. But it happened in long-term care.
Samir, I see you want to jump in there.
No, and I think partly, I mean, again, I think it's, trying to fight something out in the courts, kind of, again, it's what's the end game. But this is actually how MAID became legal in Canada. It was basically something that was decided through the court system to give Canadians the right to have access to that. So the key is, if we need to go through the court system so that we can actually respect the human rights of older adults and their caregivers, well, maybe we have to do that. But I think that we're just better than that as a society where we can figure it out without having to do this. But, families are looking for answers, and too much has gone wrong repeatedly during this pandemic that, I think everybody has the right to pursue the ways they want to, but we have to think about how we move forward on this.
And Michael, we talked about how even within Ontario, there are various ministries responsible for different things, but we also have we don't really have a national system. We have all these 14 levels of government. Is that federal, provincial, territorial mess, is that an impediment to fixing this?
I don't think it has to be. To the extent that any jurisdiction in Canada has a sort of responsive approach to its own population, some provinces are younger than others. I'm certainly not prescriptively averse to keeping it under provincial jurisdiction, but I think not specifically because the Canada Health Act isn't a good tool to use, or that the federal government couldn't step in and offer national sort of standards and funding to go with it. But to Samir's point, and to the point about court challenges and so on and so forth, having worked in politics, the one thing I'm concerned about is that we expend too much political capital and energy worrying about the jurisdictional boundaries, which I think are important. But I think in the immediate aftermath of COVID, where I would prefer our governments and our leaders and decision makers to be as focused on improving care as quickly as possible, following the best practices. I really don't, I think there's going to be a time and a need for answers, for finger pointing. But what I'd prefer is to not have that overtake the conversation in terms of how we actually improve care. If we make it a jurisdictional battle, if we make it about our rights and responsibilities between this level of government or that, I think we risk spending too much time in political energy on the wrong issue.
Okay. And Samir, I want to come back to we've mentioned dementia a couple of times in passing, but that's a particularly challenging group to care for. So a lot of questions that are coming in, people are saying, how do I ensure my loved one with dementia is cared for and I don't have to give up my job to do this? How do you get that balance right?
Yeah, and I think part of this is that, again, we know that the number of people living with dementia in our society is over 500,000 right now, and that number is going to double within the next 10 or so years. And that's partly just because dementia is one of those conditions that's highly associated with aging. And we're seeing this whole challenge where the majority of the care that people with dementia get are from family caregivers, from friends, neighbors, and this, and much more than what government-funded home care or even long-term care actually provides. So even those who are living in long-term care settings, sometimes have their families who are supplementing themselves, their time, or hiring private caregivers to provide that support. So dementia is one of those cruel things where we don't have a cure, we don't have effective treatments, but really it's actually creating environments, whether it be at home or in our communities or in specific, institution-like settings where we know that there's a number of things that we can do, but that really requires an investment in staff, that requires an investment in training, that requires us to actually acknowledge that these aren't easy things that we can do. And if we want to do it humanely, we have to do it well. So these are the things that we have to do, because frankly, when we can't, when it becomes a choice for, a daughter or son to give up their job or a promotion, so that they can provide that care for their loved one. And I know many patients, whose families have done that for them and been heroic in that. It means that it actually negatively impacts our economic productivity. It also affects these individuals who also have the opportunity, to try and live their lives to the fullest as well. So I think the challenge is that we've created a system that's not allowing us to provide the best dementia care possible. And that really can happen in a variety of settings. But just like we have these systemic vulnerabilities, there are things that we know we can do. And if we do them, we can better support people living with dementia. But right now we have a dementia strategy we launched last year. I'm on the Ministerial Advisory Board for Canada, advising the minister, but there hasn't been a lot of movement as of late because we've been focused on COVID. And I'm worried that dementia strategy that started off with a bang may not get the attention it deserves, moving forward.
And as sort of a related question, a number of people, our viewers, are asking, they're saying we don't have access to a geriatrician. There aren't very many. How do we ensure that family doctors who do most of this care of people as they age, how do we ensure that they can manage this complexity of care as people become frail, as they have dementia? How do we ensure that the family docs can do it?
Well, here's a secret that I think most Canadians don't know. So I want to thank everybody out there who actually helped subsidize my medical education. You probably would be delighted to know that my curriculum and the curriculum of every medical student in Canada includes training in pediatrics. I did 6 weeks at the University of Western Ontario. How much training in geriatrics did I get? I got 2 weeks, and that's because I chose to learn it as an elective. So right now in most Canadian medical schools, if not all, geriatrics is actually not a mandated thing that we have to learn and be trained in. So we're graduating in Ontario out of 6 medical schools, a whole legion of medical students every year, where if they learned geriatrics, it was on an elective basis, it wasn't mandated. And so a lot of my patients come and see me and they say, I don't think my family doctor likes me. And I'm like, hey, it's not that they don't like you. They're terrified of you because they haven't been taught how to care for you as you age. And we know that when we don't expose people to this level of training or these opportunities, then why would they want to consider a career as a geriatrician? And this is why we have this curious mix of 9 times as many pediatricians as we do geriatricians, when older people now outnumber younger people. So the basic thing, how do we start doing this better, is we need as taxpayers to say, hey, wait a minute, I'm funding the medical education of all these folks. I wouldn't mind if they're actually trained to look after me and the rest of our society as we age. But former well-known as medical school dean, Duncan Sinclair from Queen's University, he took me aside one day and he said, Samir, I'm going to give you a piece of advice that every dean gives to an incoming dean. Shifting curriculum is like shifting a graveyard. And when you start actually saying, okay, we want to add in some geriatrics, well, who's going to volunteer to have their important part of medicine cut out? And again, it's politics. We know what we need to do, and we should be doing it. But I think it starts by making sure that at that fundamental level of training, we make sure that we're mandating training in geriatric care.
And I know the more white hair I get, the scarier I get, apparently. So I get that from my doctor as well. So, Margaret, we have several questions. A couple of people were very intrigued by the mention at the outset that you are involved in age-friendly communities. So people are interested to know what is an age-friendly community? And then a lot of questions about coming back to most seniors are healthy. How do we ensure these healthy seniors have a good community, that we build communities that keep them there and not shuffle them off to institutions?
Okay, so age-friendly communities is basically almost like a framework, a prototype that tells you when you step out of your door into your community, what are the things you need to age healthily there? So it could be benches when you're going to go get your groceries. It's having groceries nearby. It's having access to social activities. It's having transportation. It's income and housing. It's all those great, what we call the determinants of health. And what it did was it set up a scale basically that said, here are the things that you need to have to age well in your community. And it was based on 32 cities around the world. And it was shocking how common all of the concerns and comments from older people when we were setting it up, excuse me, were. So I mean, it basically looks at how to have a community that allows you to age healthily. And what's really great about it, because I was at the federal government at the time, was it's the only program I ever, worked on with the federal government where all the provinces took it on and never asked for a cent, because it really allowed them to determine where and what they needed by using this guideline.
I think we're having a little trouble with your line again there, Margaret.
It looks at things again here.
Great, we're having a little internet problem with you there again. We've got most of that. So, Mike, I saw you, okay. Michael, nodding. I wonder if you could build on that. How do we make our communities more amenable to seniors so they don't end up in care homes as early? How do we just make it easier to live?
Well, there's actually a great example from our backyard. So 2 years ago, Samir and I approached the president's office at Ryerson University. That's where our institute is based. And we had heard about the Global Age-Friendly University Network. And we said, look, why can't Ryerson be there? If we join, if we meet the criteria, we would be Canada's largest age-friendly university. And then you look at the criteria list and you realize that, Ryerson being downtown Toronto is actually checking off pretty much all of those elements, right? It's accessible physically, or it's striving to be. It has a thriving community of older students, whether it's the Life Institute. I think it's the largest lifelong learning program attached to a university in North America, the Chang School. So in a sense, these conditions have already been operating. And what we were able to do is just shine a light on and say, look how important this is. This is a part of Ryerson's community that it could broadcast to the broader community, that it's not just, people in their 20s coming to school to get an education and a career. There's an integration of generations happening organically underneath us. And I think, to Margaret's point, where it's not there, where an age-friendly component isn't there, we should build it. But where it is there, I think we should do a lot more work broadcasting it, promoting it, because I think that'll bring the people out. That'll bring older people out to a place that they know has been designed in a way that's friendly for them, that's culturally appropriate as well.
But if I can throw in there, there's also two really good policy examples that, again, I believe heavily in investing in R&D, and people think that's research and development. It's actually called rob and duplicate. So as Margaret was saying, there's people who figured this out and done it really well, and they published on it, and they want people to actually steal their ideas. So two really easy ideas, and I'm going to bring this from Denmark and 10 other countries around the world. But what they do is when you turn 75, you actually get a visit from a public health nurse who comes to you in your home and says, hey, let's take a look around your house, because if you're planning to age at home, these are some of the adaptations you might want to think about doing while you're well, so that you can stay living here independently. And this is how you do them. And this is where you get connected to home care. And there's a seniors club around the corner, and all these sorts of things to stay healthy and well. So we have well baby checks that are provided across Canada by public health nurses. Denmark just said, we're going to do this when people reach that ripe old age of 75. The other thing that happens is that in 10 countries around the world now, Australia, Denmark, the UK, they've actually changed their home care programs to do something called reablement. And it's the idea that right now we have a system that does things to people as opposed to doing things with people. So when a person comes out of hospital and they have trouble bathing, for example, we'll send in a home care worker twice a week to go bathe you. But if you ask that person, do you want this person to come bathe you at the age of 88? They probably say, I'd rather just do it myself. And often people are probably out there saying, my mom always kicks out the home care workers. Well, imagine now in these other countries where what they do is when they assign a home care worker, they also put in a physiotherapist or an occupational therapist to say, Andre, do you want to bathe yourself? And you're like, yeah. And they said, okay, well, let's do a little exercise program to get you to be re-abled to do that activity. And then lo and behold, these systems have cut their systemic home care costs by 10%, and they actually have happier people who are more independent because they've learned to be able to become independent once again. So this is about smart policy meeting the needs of people to help them stay healthy and independent in their homes longer. And I just talked about two ideas that save money. So what gives? Why don't we just go ahead and do it?
Great. Unfortunately, our hour has gone by really quickly. We're almost out of time, but I think that's a great note to end on. Let's re-able our elders to be able to live in society, build a better society, get them in the appropriate care, whether it's at home, in an institution, make our society more senior friendly rather than hostile. So great comments from you all. I thank you. And I'm going to throw it back to Mike Van Soelen for a few closing comments. Thank you, everyone.
Thanks so much, Andre. Thanks to Samir, Michael, and Margaret for all your comments. It was deeply insightful. I'd like to turn over to Bruce Mahoney, Executive Director, Toronto Central Home Instead Senior Care, to provide proper appreciation.
Thank you, Mike. On behalf of our sponsors, Home Instead Senior Care and Home Care Ontario, thank you all for taking the time to speak with us today and lend your perspectives on the challenges facing the senior demographic. I trust that everyone in attendance found your discussions as insightful as I did. To me, the dialogue truly helped bring to life the importance of our society committing to changing our collective thoughts and attitudes towards seniors, aging, and where they're cared for. Collectively, we must all accelerate the transition towards senior care models that better leverage public, private, community care, and volunteer organizations in our quest to provide higher standards of service and care to our aging population. It's been a pleasure joining you as a listener. I thank you for your time, energy, and commitment to serving our seniors. Have a great afternoon, everyone.
Thank you.
Thank you. Bye, everyone.
Thanks, everyone. To all our viewers who watch, we had unprecedented questions. I hope we got to the topics that were most important to you. Please look at our website for further events coming up. Thanks for your time. This meeting is adjourned.